down at, initially I've been at Valley Regional for, down in Claremont for 11 years prior to coming up to Alice Peck Day Hospital this past year. And the main reason, the main reason for coming up was to work with our CEO, Sue Mooney, who I've known for a long time, who is very progressive and forward-looking about healthcare delivery on the community level. And, you know, and to start what's called the patient and family-centered care model. So I didn't want slides. I have slides that are, I think, too busy. I want you to be thinking about your experiences, because that's really what it's all about. So when what I call the Accountable Care Act, but the Affordable Care Act, reared its to date ugly head, it forced us all to think in different ways. Like, what are the changes coming? How are the changes coming? How are they going to affect it? And I'm sure everyone in the room has heard an awful lot about this and that, and Ted Cruz is ranting against it, and he's going to shut down the government for it. But what is lost in all of this hubbub and hullabaloo is what it means to you, to us, to the patient. You don't hear, okay, how does this affect patient care? Like, how did on the ground level, like through the patient's eyes view? It's what does it mean? What is Affordable Care Act? What is CMS? What are all these things? What gets lost is you, the patient, and what you're going to go through and how you're going to go through it. So when all this started up, I was like, how can I, as at the time a solo practitioner in a small community hospital in the woods of New Hampshire, do something to affect patient care and healthcare delivery on that basis, and get ready for these changes. So I went to a meeting down in Washington, D.C., and the topic of the meeting it was put on by Orthopaedic Society, and it was called Shifting from Fee-for-Service to Value-Based Medicine. And so this is what the Affordable Care Act or the Accountable Care Act, however we want to call it, is about. It's taking it and saying that we now are going to be not just being paid or paying out for care, no matter what happens on the outcome. Like, I'll put in a total knee, or I'll put in a total hip, or I'll do this, or I'll do that, and I'm going to get paid, and it doesn't matter how you do. We have to be accountable for what the outcomes are, so how do we take control of that, and how do I take control of that as a physician, just wanting the best for his patient. So I was very confused going down. Not that I'm much less confused now, but saying what can I do? And a physician down there, Dr. Tony DeJoy, who works at Pittsburgh Medical Center, it was a total joint surgeon who does a lot of surgery, and he developed this program that is, it just made intuitive sense to me. A light bulb went off, said, oh, this is how he does it, and this is how I can do it too. And that's why, that's the main reason why I want to shift to Alice Peck Day to start this program. So what is patient and family-centered care? It's what it should be all about. It's about seeing the experience, whatever the experience is, through your eyes. So if you think of an experience, so say you want to call me, and you want to have an appointment because your knee hurts, and you call the phone, and you guys probably haven't had this experience, but you get a number. If you are having billing, choose 1, choose 2. You guys ever have that? Yeah. Okay. Then you finally get somebody, and who are you going to see? Well, I want to see that. Well, let me take your information out. Then you take your information out. Then you come to find me. And then, well, am I in the Alice Peck Day, or am I in an outbuilding? Am I in the front of the outbuilding or in the back of the outbuilding? You finally find me. You're 15 minutes late. And then they hand you another sheet. And he's like, I just told you that on the phone. Like, now you're repeating your experience. So now you're grouchy by the time you get to see me. How's your knee? It stinks, and why do I have to do this paperwork? So it's taking it through the whole experience, whatever the experience is, and through your view, and this way we can see where we are not performing up to snuff, or where we are performing up to snuff, and make it better. So in how do you do that? Well, the main way that we're going to find out how is by shadowing you, by seeing it through your view. So in my clinic now, and they have made a beautiful new office setting. They painted all the walls, and they put in new chairs and new everything, and new paintings on the wall. And so we have had students come, physician's assistant students come and be with the patient through the whole experience. So from the time they come in until the time they leave my office. And the patient will tell that shadower exactly what, this was a pain, there's no privacy here, this is, this was good, this was bad, they were very nice. And so we have begun to accumulate data that says these are the areas that we can make it better for the patient, and hopefully better for us as well if we know what's going on through the patient's eyes and the patient's viewpoint. So already, right off the bat, we've done it about 25 times already, but we know my waiting area is too small, there's no privacy in my waiting area, the door is hard to get into, so they have this brand new thing and we have to tear down a wall already. But this is going to make it better for the patient, and better for you when you come to visit us, and better for me because you're going to be happier and things are going to be smoother as we go through. Now, how does this translate to a bigger, like how this is going to affect my giving healthcare on the community-based level? But what is going to be important, what is not being said about the Accountable Care Act or the Affordable Care Act, however you want to say it, is that how you feel and how you do is going to measure how we get paid. So it sounds a little crass, but it gives the power to the patient, and it makes so much more sense. So when you go into the hospital to have a total joint surgery, you are going to be asked a set of patient satisfaction questions, and it's called the age caps, but they're going to use the age caps to base it to say, how does this hospital stack up against other hospitals like it for patient satisfaction? And if you do not stack up, you're not going to get paid, and that gives the power to the patient. So what does that mean when you come in? So for Dr. DeGioia, he thought he was, the cat's meow, and that his age caps were going to be through the roof because he takes very good care of his patients. But his patients were not very happy with the experience they were having in the hospital. So he not only did shadowing, but he put cameras in the patient's room to see what was going on after a total joint. So I'm just going to ask, because this kind of blew me away. So in the first night to day, from the day you get out of the surgery to the next day, how many times do you think anyone came into the room of somebody who had just had a total joint? Anyone?
I have no idea.
So from the day you get out until the next day, so it's not even a 24-hour period.
10.
A lot.
35. 86 times.
What?
Yeah. So that's what he said. So that's what Dr. DeGioia said. So he said, this is unacceptable. No wonder that they're tired, they can't sleep, they're not eating because they can't sleep. So he made it so that people, cut down the number of times, so now they have it down to between 20 and 24 times. So if you're going to go into a patient's room, you better have a good reason for going into one of his rooms. So the other thing, the other huge part of how this system works is you say, what is my care experience? So you can take it from total joint, so a total knee, from the day you start to the day you get discharged from the hospital, or you can say, or discharged from the clinic, or you can say the total knee from the day you come into the hospital. You can make whatever experience it is. So right now, my experience is you coming through my clinic. But every single touchstone, every single interaction that you have is now, that interaction is part of your care experience. So what made, again, this intuitive sense, and just that everybody along the line is part of the caregiving team. So again, I'm going to use Dr. DeJoy, and he fortunately is very generous, and a lot, you know, he wants this spread so people can take it this way. But he works in Pittsburgh. His hospital has, you know, very hard to park, so people would be getting late for surgery and late for whatever. So he said, we got to fix this. So what he did was say, here's a touch experience, parking. They got the parking attendants, and they essentially said, look, you're part of the caregiving team. Help us solve this problem. So now they have valet parking that they get in and they aren't late. So he's able to see patient after patient who is not late because they have valet parking. And now the parking garage feels like they are part of the caregiving team. So everyone along the line, from the person who answers the phone, to the person who checks you in, to the person who brings the oxygen around, and whoever has any contact with you as a patient becomes part of the caregiving team. So if you find, and this was another, you know, issue, that the guys who were bringing the oxygen to the intensive care unit were rumbling the cans through the hallway, keeping everybody awake. So they said, look, you guys fix it. And they were able to make canisters padded so it didn't make noise. Now that's a little thing that can turn into a big thing if you're the patient trying to get moments of sleep between 86 other people coming into your room. So if you take all of this and say, you're going to make your experience, we're going to see the experience through your eyes, and we're going to fix these things, and they're not big, expensive things. So at his hospital, McGee Hospital, they have a kitty for any project. So that if you say you want to fix the canisters, or if you want to have LA parking, so the kitty is no more than $2,000, and they never use more than $1,000 because it's taking people, it's giving them, giving everyone in the care environment ownership of care of the patient, and they want to fix the problem and then have it done. Now it's better for the patient, you can move on to the next project, and it's a constant refining to make it efficient so that the patients are happy, you're seeing your patients, they're not late because of parking, they're not grouchy when you come in because you're the 87th person to see them, and their HCAHPS go up, and your outcomes get better as part of that HCAHP getting better. But it also is with the therapy. So if you have, you know, 2 times of therapy a day, and you're not, and your pain isn't controlled, how do you get that pain controlled so you can do your therapy, so your objective outcome of not a stiff knee and a good working knee, then you need to work with the pharmacist and the nurse and the, you know, so whoever that team is that you make, when you find, well, your pain isn't controlled enough when you go to therapy, we need to make sure your pain is controlled so you get your pain medication in enough time that it makes a big difference so that you can do the therapy that you need, so you can leave sooner, get out of the hospital sooner, get back to doing what you want sooner. So it's revolutionary in that it's not thought of this way, but it's so basic that why aren't we thinking about it like this? So this is what struck me most about how I personally can affect positive change for my patients and get ready for the coming changes in the Accountable Care Act, Affordable Care Act. And the other thing that's a huge portion of this is patient and family-centered care. So it is very important to have the patient with a family. So if somebody comes in and they come in and they said, okay, I'm getting ready to have a total knee. Okay, you're going to do a total knee, and the infection rate is very low, but if you get an infection, I got to take the knee out, and you're going to be on 6 weeks of antibiotic, and what happens? You know, you stop thinking about what you're saying, and then you're going to go home. What did he say? Infection. All he said was infection. So you need a family member or a friend or some help with you along the way, because otherwise you're, I get nervous when I go to my doctor, and I don't hear what she says, and, did you pick up your medication? So we need to get, we need that to get the best possible outcome, to get the best possible result. So I was able to set this up at Valley Regional, and it's something I'm continuing here, where we have a joint school. So when you're going through a joint school, making the choice of having a total knee, it's a little more intensive for a total knee than for a total hip, but for either, that you come in and you meet as a group, and you have to bring a family member, you meet with that family member, and other people who are going to go through it in the same time period, and then the therapist comes in, and the nursing comes in, and the discharge planner comes in, and the anesthesia person comes in, and they tell you, this is what's going to happen. You're going to be on this machine. We're going to move your knee. It's going to hurt. We're going to help you. You're going to be on this. You're going to be on that. You're going to have a catheter. So and then they're able to ask questions from their point. Okay. Well, what about? Oh, I didn't get that. Did Dr. Houde tell me that? So they're able to. So by the time they come back to me to sign the consent, you say, well, these are. I know what the risks are. I know what that. I know. So they know, and the more you know, the better it's going to be for me, the better it's going to be for you, the better it's going to be for outcomes, the better it's going to be to get ready for all the changes, but it's better for you. And that's why I'm doing it.
Very good.
Thank you.
Cool.
Questions? I wasn't that descriptive.
I like the idea that somebody is talking to you about what kind of anesthesia you're going to get before you get it. And I hate needles.
Yeah, I hate needles.
And to have perhaps a choice of anesthesia, which hasn't happened until I spoke up and said, I didn't like all the poking the last time I was here. You have one shot, and that's it. Otherwise, I'm leaving.
Well, that's what
But it did happen. But it wasn't until I spoke up and asked. I wasn't told of options I could have.
Exactly, and so
I think that's so important.
it's very important. And that's something that I learned along the way too. Like. I said, okay, I'm going to tell you about the surgery. It's not my job to really tell you about the anesthesia. And I also, I do a lot of shoulder surgery, and we like to do what's called an interscalene block to block the shoulder. It's an invasive procedure, and so if they don't know that when they show up on the day of surgery, it's going to crank their nervousness or agitation, like, whoa, no one told me I'm going to get a needle and a needle. I just got this needle. Why do I need another needle? So it's my job, and that was something that, if I wasn't listening or hearing the patients, I had enough patients say, Dr. Houde, you should have told me about that, and I should have. So now, when I tell anyone about a knee surgery, if we're going to do a knee surgery, we like to do the femoral blocks, we like to do the interscalene blocks for pain, but it's your decision. If you don't like needles enough that you don't want it, I'm not going to force it on you. You're in the driver's seat. It's your body. It's your experience. We need to know from you what you want, but I need to be able to tell you, and the system needs to be able to tell you to get you better prepared. Because the more prepared you are, just like Dr. Tomek said, the better you're going to do, the better outcomes we're going to have, and everybody's going to be happier. So,
Thank you.
thank you.
About how long would you say it would take to get all the new changes implemented throughout the system? How many
My
years?
system or the
No,
whole system?
At large, globally, what do you think?
We've seen the fits and starts of what's going on right now. I do know that whatever it looks like today is not what it's going to look like 6 months from now, and it's not going to. But it's the start. It's the law right now. And I do know that this past year, and if I'm not too far off, by March they had hoped to pay out a total of 700 to 800 million based solely on the new system this year. And I know that they had paid out over $1 billion by April. So it's here, it's happening, and it's happening now, and we have to be ready for it. So if you say, well, I'm just going to wait and see, you're going to be behind the 8 ball. And I know for us as a small hospital, it is critical to be knowledgeable about that. And now at this meeting, orthopods aren't known for being very, they don't like to give up their piece of the pie very well. And Dr. Tomek, he's probably the most generous orthopod you'll find, but most are, and at this meeting, a guy in a very fancy suit and a very fancy tie got up and said, I make money from my hospital, I make money in my clinic, and I don't see any goddamn reason to change. And Dr. Weinstein was at this, he said, don't change, the train is coming, it's going to run you over. And the guy, and so the change is happening now. And if you're a fat cat and you can retire, great. But for those of us who want to see better medicine, better orthopedics for our patients, we want to stick this out and do it right. So it's happening now. So again, I would love to have that crazy 8 ball. What is it going to look like? Ask me later.
Probably the biggest part of the problem will be to get the different departments to talk to each other, and then after that, it shouldn't be that bad.
I'm going to quote you. We'll come back and we'll see.
Like Congress.
Yeah, like that.
Yeah. Yeah, like
I like that. Excellent. Oh, I'm sorry.
That's okay. I'm really fascinated by what you're trying to do. And I don't know if I have a question or a comment, but I'd like, it seems to me, I read a study years ago, like in the 1980s, where it said that patients who are going to see their doctor and they're often sitting in a cold room and they're naked and only wearing a Johnny, these people aren't feeling very empowered.
No, exactly.
And so it seems like one of your biggest challenges is to how to teach your patients to be more a part of your team,
right,
instead of being passive.
Right, and that's exactly it. And if you, and this is, and Dr. Tomek, segued, very nicely. He's talking about shared decision making. So that's essentially, the same thing. They're saying, we're not going to make this decision for you. And I tell all of my patients that I don't live with your pain. I'm not the one getting up in the morning and stepping down and going, oh, and I'm not the one getting out of the car and going like this. And so when we have somebody who is like shadowing with them, they sit, they're quiet, and they open up, and they really open up. And that's, but you want to shadow and shadow again. But the other thing is a patient and family. Now, I just love this. We had a couple, and they've been a couple for a long time, and he said, I don't need a hip. He said, you need a hip. Well, I said, do you limp? I don't limp. And she was like, almost fell off the chair. Would you please walk across the, just go. So, what, you need that family, what do you mean? You don't get up out of the chair after you sit down. So it's patient and family, and when you go home, and that's why, when I start saying the risks, I want somebody else there to hear. Yeah, Dr. Houde told you that, but he also said that, if we work this way, you're going to get all right. You're going to get through it. He's going to help you through it. And so when you go to the joint school, that's when people, if I'm not there, I don't wear a white coat, and I try to be as approachable as possible, but I'm still the doctor in the room telling you the risks and the benefits. If I'm not there, and you're sitting there with other people going through the same thing, or your family who's going to give you the nudge, ask that question. That's how you empower the patients. But that's what we need to do. We need to empower you, the patient.
I'm actually lucky enough to be involved in Dr. Houde's joint school at APD. And we've had some great luck with the whole joint school. Patients like it. Family members come.
Yep.
So it really is a great continuation because they're hearing the same thing. So people aren't coming into the hospital, I don't think, as scared because they get to see the catheter. They're seeing, the CPM machine, this machine that they put you in after surgery for your knee replacements. So they're already seeing it. It's not happening after the fact when they're maybe a little drowsy from the medications and the family's like, oh my God, what's that thing? So it's really helping a lot. People are coming out with much better.
Yeah, definitely.
Yeah. It's great, it's fun to do.
Excellent, thank you.
I'm going to appreciate your initiative over there. It's our country, we're a very consumer-oriented country, so people are looking for good service. Part of my curiosity is when we think about the system in the United States compared to systems we're looking in other countries, other national health systems. Is there any information out there that about what some of those other countries do or don't do? Have they done any of this? Do you know?
That's a good question. I'm not sure. I can honestly, I'm not sure. There's a lot of difference. We could sort of whole kick-a-boodle about how healthcare is the way it is today for here, but I do know that in orthopedics, we're a little late to the game as far as being this patient-centered. In midwifery and OBGYN, there's something called centering, and that has taken off, but that's been around for 25 years now, but that lowers premature birth rates, increases birth weight in a positive way. And in family practice, there is what's called the patient and family-centered home. But the reality is that we're all kind of, OB/GYN and midwifery is ahead of the curve. Family practice is ahead of us, but not by a whole lot. And I think it's the dynamics of what is coming down. And I think, unfortunately, it was, you're going to get paid for outcomes, and part of the outcomes is patient satisfaction. It took that for us to say, oh, maybe we should think about the way patients are, which is kind of sad. But again, it's revolutionary, but it's not so revolutionary when you think about it. But that's a great question. That's something I'll definitely look up. Thank you guys very much for coming.